Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Sinise. Glad to see you all around. If you're watching us live from any of those channels, glad to have you on the show. Hey, YouTubers, don't forget, hit that subscribe button, keep the subscriptions going, and hit the like button. I hear that helps the algorithm too. Anything to help get the show out. If this is your first time joining us, be sure to check out our uronurse.com website. The website is the best place to go to learn more about the show. And it's also the best place to go to check all of our past episodes out. And boy, do we got a bunch of them, 79 episodes. Today is episode number 80. Also, want to listen to us in your car? No problemo. Check out our UroNurse Plus area, and you'll be able to listen to us on any of your favorite podcasting platforms. Also, if you have a question, be sure to use that comment box. And, whoops, wrong way. If you're not getting the email, go ahead and go and fill our box out on our website to get the email. Every Monday, an email comes out with interesting information about the show. And talk about show, we've got a great show coming up this week. Margot Lee is going to be joining us from Pathnostics. It's going to be we're going to talk about infections, those nasty urinary tract infections that pop up, and how we can leverage the new technology to really get a better culture. So we're really anxious to get more information on that. And with that, I'm going to go ahead and bring my experts into the show. Experts, welcome to the show. There they are. Hey.
Good morning, everyone.
Good morning. So I'm going to kick off my introduction. My name is Vic Sinise. And again, I'm a registered nurse. I've been involved in urology for over 40 years. Really enjoyed my career and continue to enjoy it. But I wanted a way to give back. And that's what UroNurse is all about. And it's been a great journey to give back to a profession I enjoyed so much. All right, let's bring in the rest of our expert panels. Lori, go ahead and introduce yourself.
Good morning. My name is Lori Atkinson. I am a certified urology registered nurse. I've been in urology for 25 years now. I'm currently working for a urology practice in Winfield in Geneva, Illinois. Very excited about the talk today because we do use this in our office, and it just confirms what we know and what we love about it. So hope you guys enjoy it.
Great. And John, go ahead and introduce yourself today.
I am passionate about helping urologists succeed in the business of urology. And to that end, I created the Thriving Urology Practice Facebook group where we crowdsource practice management solutions for everyone's benefit. And it is all for free. I'm John Lynn, a private practice urologist in Gilbert, Arizona, and I look forward to our discussion today. And as we are recording this on Super Bowl weekend, so go Niners. No.
Well, you got Mahomes in the audience too, so maybe even a few Swifties, right?
That's right.
Lace, go ahead. Your introduction.
Good morning, everyone. I'm Lace Heidemann. I am a registered nurse certified in urology. I've worked in urology for over 10 years. I really enjoy being a part of this awesome show and really looking forward to the discussion today.
All right. I like that awesome part. Andrea.
Good morning. My name is Andrea Strong. I'm a urology nurse practitioner in Wisconsin. I am certified as a urology registered nurse, and I've been working in urology now for 14 years. I'm also the educational director for the Chicago Metro chapter, and I'm on the board of directors for the National SUNA program, and I'm really looking forward to this presentation today.
And if anybody's ever wondered who all the experts are that join us, now we've introduced ourselves, I've got the whole panel on today, so it's really a neat treat. And I worked it out with a big panel so that sometimes people have things going on in their life, so they're not always available, but now you've met them all. All right, with that, we're going to bring in our presenter, Margot Lee. Go ahead and present and introduce yourself, and then we'll bring your slides in.
Very good. My name's Margot Lee. I am a senior medical science liaison at Pathnostics. I have a background in molecular diagnostics. I've been doing molecular diagnostics and supporting this technologies for 30 years now. And I'm here today to talk about guidance UTI and looking at recurrent, persistent, complicated UTI cases. So it's a really timely topic, and technologies have changed, and I thought this would be a really wonderful time to sit and talk about what we know with uropathogens, antibiotic resistance, using these molecular diagnostics, and then also talking today about our guidance UTI test.
All right, great. I'm going
Yeah.
to go ahead and bring your screen up here and take it away.
All right, wonderful. Well, thank you. Well, what we talked about is that we're going to discuss today about these emerging uropathogens that we see in these recurring UTI cases. And so looking at that, looking at antibiotic resistance in these uropathogens, and then also now talking about standard urine culture, some of the limitations that we're seeing and where molecular diagnostics are going, and then also talk today about guidance UTI, which is a unique test that's used to treat these recurring, persistent, complicated UTI patients. So we know there's urinary tract infections, and this is a big issue in today's public health. We know that in a recent report that we saw that there were 600,000 hospitalizations per year that we see from these UTI infections. We also know that they can be very expensive. So the report, I think it was a 2018 report, saw that there were $44 billion spent on treating patients with UTIs, with urosepsis. So it is very expensive. And we also know that these patients frequently end up in hospitals. So it's very timely to sit and talk about urinary tract infections. So what's a urinary tract infection? It can be an infection anywhere. We talk about an infection in the bladder, so that's cystitis, but we know that these organisms can enter into the urinary tract through the urethra, and it can go through all the way from the bladder all the way up into the kidneys. So it really is something that needs to be detected and treated effectively and quickly for these patients. So what are some of the common symptoms that we see in a UTI? Well, there's pain in the abdomen, pain in the back, pain while urinating, there's fever, there's many times frequency to urinate, and there's also can be pain during urination as well. What are some of the risk factors that we know that commonly go with a UTI? Well, we find it a lot more in females, and we know that anatomically that you have that that it is going to happen more frequently in females. We know that a risk factor is you've already had a UTI, you're more likely to have a recurrent case of another UTI. Sexual activity can increase your risk factor. Changes in the flora, in the bacterial flora in the bladder, so hormonal changes, so menopause, pregnancy. Those are all issues that can be fueling a UTI. Age, so we can see whether an elderly person or a very young person could be more at risk for developing a UTI. There also could be a structural issue that's going on, like in a large prostate, and of course, poor hygiene. So that all these issues together can fuel that development of getting a UTI. So now you have a patient that you suspect have a UTI. So what do? Well, you're going to manage this patient. So you're going to start with a good clinical background. So you're going to understand the general overall health of this patient, what they're coming in with, some of their symptoms. Then now you have to choose an appropriate diagnostic tool to identify the organisms that are present in this urinary tract infection. And there's many. There's point of care. So there's a urinalysis one. There is, we've had urine culture with antibiotic sensitivity testing, and that's something that we've had for a long time. It's considered the gold standard. But more recently, we have molecular diagnostics. And so you see multiplex PCR, and guidance offers multiplex PCR, but it also has a two-part. So it has multiplex PCR, but it has a pooled antibiotic susceptibility test. And we're going to talk about that a little bit further. But now, once you've diagnosed what organisms, what antibiotic resistance you have in this patient infection, then you need to choose an appropriate antibiotic that can help treat this infection. So once you're looking at this patient and you see this UTI, most frequently you can treat it and you will use an appropriate antibiotic and help treat this patient. But in about 25% of the cases, you'll have a reoccurrence. So somebody will come back in 6 months and they'll have another UTI. So more frequently you see patients that are immunocompromised, or there's an anatomical abnormality in their system. There are many different reasons why you'd see people that would keep coming back. And it's very important to look at this patient carefully and appropriately and use these diagnostic tools, because frequently a reoccurring complicated UTI case can cause sepsis. We know that 25% of all sepsis cases in the United States are urosepsis cases. They frequently end up going to hospital. So we can see these organisms go from the bladder up into the kidneys, cause abscesses in the kidneys, and even use loss of kidney function. So it can escalate very quickly. So it's very timely to talk about this so that we can get these patients treated appropriately quickly so they don't end up in the hospital. So one of the first things we do is we look at uropathogens, and we want to know which organisms are going to be present in these recurring UTI cases. So the guidance test looks at 27 organisms, and they're different bacteria. There are gram-positive, there are gram-negative, they're fastidious organisms. We also have some fungal. We have some Candida on our panel. These are the ones that we see most frequently. So these are the ones that are clinically relevant for these reoccurring UTI cases. So we have 27 organisms that we detect, and we also look at 3 different bacterial groups. We can detect an ESBL phenotype, which is extended spectrum beta-lactam phenotype, and of course, methicillin-resistant Staph aureus phenotype. So we talk about gram-positive, gram-negative organisms, but we also know that there's fastidious uropathogens that are part of the UTI panel. And so guidance will detect these organisms. And these are ones that if you do a standard urine culture, they grow beautifully in the body, but they do not grow well in standard urine culture. So if you do a standard urine culture, they're not going to grow. They need a specialized enhanced culture environment to grow them. So standard urine culture, they just wouldn't be detected. And so this is just kind of the list that we have that we know that are clinically relevant and play an active role in these polymicrobial UTIs. So you can see Actinidium shallei, Escherichia urinae, Alloscardovia omniclens, Corneobacterium, Gardnerella vaginalis, Ureaplasma, Mycoplasma. And these are all ones that we're talking quite a lot in the scientific literature now, and they're all captured here in the guidance UTI panel. And one of the things that talking about uropathogens is that we've come from a place where 50, 60, 70 years ago, we knew that E. coli, a UTI was all E. coli. So if E. coli was there, you had a UTI. If it wasn't there, it wasn't there. We used to think that urine was sterile. So we would just detect an organism. If E. coli was there, we knew that it was a UTI. But we know now that knowledge is changing, and that we understand that there is a urinary microbiome of all different organisms. And I thought this was a really nice image to share so that you can see some of the different ones that you could sit and find. You could find some of rods or some of bacillus, and they're all there. They're all part of this urinary microbiome. So it's very important to be comprehensive, to take a look at what you're seeing in these recurring complicated UTI patients. So when we talk about uropathogens, what are some of the characteristics that we look at when we are trying to kind of characterize them of what we're seeing? Well, we talk about gram staining, which we all know. And gram staining is when we actually apply a specific stain to these bacteria, and we can see that the cell wall becomes a big, thick purple line around it, and that's because it has a thick peptidoglycan layer in their cell wall. It also could be very thin, and it could be pink, and that is where you consider gram negative. And a gram negative has a very thin peptidoglycan layer. So organisms are in microbiology specified as gram positive, gram negative. They're also specified as aerobic, meaning that they need oxygen to grow, or they could be anaerobic, which they don't need oxygen to grow. And we see that also in UTIs, as we see gram positive, gram negative. We see they're aerobic, anaerobic. We also see fastidious organisms, and that's what we were just mentioning with the previous slide, is that there are many organisms that cannot be detected using standard urine culture. So, but we know that they're there. They play an active role in these polymicrobial UTIs, and they need specialized enhanced culturing environments to have them grow. And it takes longer, it takes different nutrients, different growth factors. So I know in the laboratory, there's different organisms that can take several weeks to grow these organisms. So people are not as familiar with fastidious organisms because they haven't been able to be detected using standard urine culture. So now we've talked a little bit about some of the uropathogens that we see in a UTI. So let's talk a little bit about some of the diagnostics that we currently use to look at these UTIs. So there's culturing. So we've had standard urine culture for a long time, and we'll talk a little bit more about that. There's also expanded quantitative urine culture, which is what we are mentioning now, about an enhanced environment where you're adding different growth factors, different nutrients, different environments to help grow some of these organisms that really don't like to grow outside the body. There's also distillation versus pooled antibiotic susceptibility, and we're going to talk a little bit about that, and that's looking at antibiotics and antibiotic resistance to these organisms. But now we're also talking about molecular diagnostics. And molecular diagnostics now are being used to help identify these uropathogens. So there's polymerase chain reaction, PCR. There is DNA sequencing, which also is applied to UTI. And then, of course, we have our unique test, which is our guidance UTI test. And we'll go into a little bit more detail about each one of these. So what are some of the qualities as a clinician that you need to look in a diagnostic test? Well, you have to look at that precision part. You have to look at, is it going to reproduce the same result every time you use it? The accuracy of the test, the sensitivity. So is this going to identify a person who has a condition, and that will show that positive, that true positive? Is it going to be specificity? So is it going to identify a person who does not have the condition or the organism that you're looking at? So is it a true negative? And also the predictive value of the test. So these are all values that you need to look at when you're identifying, you're looking for a good diagnostic tool to help with your patients. So standard urine culture, that's one of the ones that has been around a long time. And looking in the literature, I can't believe it, but culturing has been around for thousands of years. And standard urine culture really began in the 1950s. And you can see, I took a picture there. You can see that's an agar plate, and you could see an organism growing on that. And that's actually how they isolate this organism. So nutrients and these growth factors and carbohydrates all are on an agar plate. And this one in standard urine culture typically uses about a microliter of urine. It's on a sheep's blood McConkey agar plate, and it's grown traditionally for about 2 to 5 days. And about 2 to 5 days, you're going to start seeing some growth. So, and this also started in the 50s when we believed that urine was sterile. So we believed in those days that urine didn't have organisms in it. And so if you could take a microliter of urine and put it on this plate and grow something, you had a UTI. Now we know also that there's expanded quantitative urine culture. And this is the one that we were talking about that takes a much larger amount of urine, but then they put different things into the agar itself. So they'll do specific nutrients or specific growth hormones. They will put it in different environments. So let's say you're trying to grow a organism that loves nitrogen. So, okay, well then you may want to grow this plate in the presence of nitrogen gas. So this is all what an expansive quantitative urine culture is that if by tweaking a little bit of the growth conditions, you may be able to grow more organisms that way. So it can grow a little more organisms and different bacteria that have specific needs, different yeasts. So it helps a little bit more than standard urine culture. But we know that there's limitations. So limitations are that standard urine culture and that expanded quantitative urine culture can't grow all organisms. They have a very difficult time. So it has limitations on what it can detect. And you have to know what organism, you have to know what you're going to place in these agar plates. So standard urine culture really doesn't detect all the organisms that you may see. Because it's a culture, you have to grow it. It takes time. So we know that turnaround time can be long. And so standard urine culture is 2 to 5 days to grow so that you can start to see the organism, the pathogen that's there. And meanwhile, it's very hard as a clinician because you have a symptomatic patient. You have to treat this patient. You have to make a decision. You just don't know what you're dealing with. So, and we also know that in culture that we will take a colony and we'll place it in a specific agar plate so that I may take a colony from a urine culture and it is E. coli and I'll grow E. coli in one plate, or I will grow another one and it's going to be Klebsiella and I'll put it in another plate, and so on. And so what you're doing is that you're essentially looking at all these uropathogens individually. So one plate will have one uropathogen, one will have another uropathogen. And this is significant because we know that in the bladder, these organisms are all together. They're all communicating, they're all sharing resources, antibiotic resistance. So there's a lot of interactions that go on in the bladder. And to look at them all in isolate in different dishes really isn't capturing any of these bacterial interactions that we know can modify antibiotic resistance. So another diagnostic tool that we can use for UTI is polymerase chain reaction. And we know that this can detect a very small amount of nucleic acid in the teeniest little uropathogen. And what this does is it can amplify this DNA so that we can detect a very small amount. And so we laughingly call it almost like a molecular photocopying, because you can take a little piece and you can just amplify until you can actually really see what you're dealing with. And this has many different forms. We talk about multiplex PCR, which is what we do at Pathnostics, but there's real-time PCR, and there is reverse transcriptase PCR as well. So there's many different types of PCRs out there. And I thought this was a nice schematic to share with everybody. Is on the left-hand side, you can see some of the components that we in the laboratory put into a thermocycler. So we take our little piece of nucleic acid, so from a uropathogen, and you could see we add primers of things that we want to amplify. We want to add nucleotides, Taq polymerase, some buffer. We put it in a thermocycler, and you can see on the right-hand side as we can start with one piece of DNA, and then we can amplify it to make 2, and then to 4, and so on, so that we can really see and amplify and detect these uropathogens, even at the smallest level. So why would you want to use PCR for UTI? Well, it has high sensitivity and high specificity. So it really is great for looking and giving you that proper identification of a uropathogen. It can detect many uropathogens all in one test. So it really is up to you to decide what targets and how many targets you want to do in one test. So it's not a test that has to get repeated over and over again. What we said is that it can also amplify a very small amount of pathogen. So, and our guidance UTI can detect even less than 10,000 cells per ml in a patient sample. And we can also detect the presence of an antibiotic resistance gene, which can be very helpful. And the turnaround time is significant. It's something that you can turn around of a PCR test could be 2 to 3 hours, which is great. So it gives you that really nice short time frame to get a result. And that is very helpful when you have a UTI patient. There's also DNA sequencing, and sequencing has been around also for a little bit of time. Sanger sequencing is the original DNA sequencing, but there's also next generation sequencing, NGS. There's also whole genome sequencing. So there's many different types of sequencing that's out there. And again, it has lots of applications for infectious disease because it looks at some of the variation that are in these DNA sequences. So it can be used to look at some of these uropathogens. And also, again, here's a nice schematic for your audience to see. You can see the uropathogens. We isolate the DNA, the nucleic acid, from these uropathogens. We can place it in a sequencing machine. We can go from double strand to single strand, and then to start looking at the nucleic acid sequence. And a lot of times it will give you some hints on what type of variations you're seeing in these organisms. So DNA sequencing identifies these genetic variations that you would see in nucleic acid, and it will detect all the organisms in a patient sample, and it will also detect an antibiotic resistance gene, the presence of an antibiotic resistance gene. But sequencing will not provide you antibiotic susceptibility. So just as it will detect the presence of an antibiotic resistance gene, it will not tell you whether an antibiotic resistance gene is actually being expressed. So it won't tell you whether that antibiotic resistance gene is actually turned on. And that's something very, very important that you have to capture when you're trying to treat a UTI patient. So looking at these diagnostic methods, we talked about culture, we talked about PCR, DNA sequencing, and these are all things that are out there right now that are used for the diagnosis of a UTI. But there are many limitations. So we know that there's missing organisms. So they may not be able to capture all the organisms that you're seeing in this patient UTI infection. We also know that especially culture looks at each organism individually, all in isolate, so that you're not capturing any of these bacterial interactions that they do in the bladder. So we know that they all are not in isolate or in the bladder. They're all together and they're all talking, communicating with each other. So you're missing all that bacterial interaction. Also, you may detect an antibiotic resistance gene, but you're not reporting susceptibility. You don't know whether that antibiotic resistance gene is actually being expressed. So that is a big piece that you have to understand. And of course, turnaround time. Many of these culture may take 2 to 5 days plus. And that's significant. You have to have a short turnaround time so that you can be timely in your treatment of your UTI patient. And so why do antibiotics fail? Now we've talked about diagnostics. Now we want to start talking about treatment. So, well, why do your antibiotics fail when you have this UTI patient? Well, there's lots of reasons. A patient may not be taking their medication, their compliance. So they may not be finishing their course. They may not be taking it the way it is supposed to be taken. A clinician may use empiric therapy and say, well, I think this works well with these UTI cases. I think I'm going to do this one. Or they may just get the wrong information and choose an antibiotic based on wrong information from a diagnostic test. There also is now in our world is antimicrobial resistance, so presence of antibiotic resistance. And we know that these organisms fight back. They are in the bladder, and when they know an antibiotic is coming and trying to treat them, they fight back. And there's lots of different mechanisms that they do so. So just recapping, we know that there are limitations to the diagnosis and treatment of these UTIs, and that's what makes it so difficult. We know that sensitivity is an issue. So we're in standard urine culture, we're not picking up any fastidious organisms. So it's missing those organisms, it's missing the yeast, and it's just not being able to pick that up using a standard urine culture. We also know turnaround time. Turnaround time, it takes 2 to 5 days plus to get a result. So you may already be starting empiric therapy. You also, unfortunately, may be giving an antibiotic that fuels antibiotic resistance. We also know that standard urine culture grows these organisms in isolate so that it's not capturing any of the bacterial interactions. When you have 2 or more organisms that are grown in a standard urine culture, you're going to get a contaminated result or a multiflora result. And that's really not helpful to a clinician trying to decide what to do with the patient. It just doesn't give you that valuable information. And also, resistance genes. We see that you can detect a resistance gene, but we also know that a resistance gene may be there, but it also may not be expressed, so that you may have a difference in what you see genotype with what you see with a resistance gene versus phenotype, what it actually does in the presence of an antibiotic. And that's really when Guidance UTI comes in. And so Guidance UTI is a unique test that's only offered by Pathnostics, and it addresses all these limitations. So this is very important, and it's been developed really to help with all these limitations that we've been seeing in standard urine culture. So it's a 2-part test. It has a PCR component to it. So we will detect clinically relevant, significant organisms that we see in recurring UTI cases. So there's 27 uropathogens, including 3 bacterial groups. We will also detect the presence of an antibiotic resistance gene. So we'll detect 32 antibiotic resistance genes. And then there's the second part. And this is the pooled antibiotic susceptibility. So we're going to take a patient sample. We're going to place it in the presence of these 19 different antibiotics. And we pool it so that we capture these bacterial interactions that we know can modify resistance. And that will give you that antibiotic susceptibility that really is so valuable to treat that patient. And it's really that personalized test for this recurring UTI. Now we've talked about pooled antibiotic susceptibility. You can see that we've talked today that there are up to 52% of these UTIs are polymicrobial. That means 2-3 plus organisms that are all together, and they're all in these UTIs. And it makes it very difficult. So on the left-hand side, you could see standard urine culture. So there are 3 dishes. You have different organisms in each one. So one will be an isolate of E. coli. The next one could be Proteus mirabilis, that could be another one. Each one will have a different isolate, and they will look at these organisms all in isolate. Whereas pooled antibiotic susceptibility determines antibiotic susceptibility when they're all together. So you can see the tubes on the right-hand side. You could see that they're all together, and we can understand what they're doing in the presence of an antibiotic. So it really gives kind of that precision that you need to see that is capturing, are they going to have that resistance to that antibiotic, or are they going to be sensitive to that antibiotic, using the patient's specific specimen. So what are some of our test details? Well, we use 19 different antibiotics. So we'll take the patient sample and we will perform this pooled antibiotic susceptibility in the presence of these 19 different antibiotics. And it's a wonderful way to kind of get a real-time look at what your patient's UTI is going to do in the presence of these 19 antibiotics before you prescribe these antibiotics to your patient. And so what would patients benefit? What patients would be best for this test? Well, reoccurring UTI. So that means patients that come back with another UTI, and it's 2 within 6 months or 3 in a year. Also persistent UTI. So someone that gets a UTI and it just doesn't go away. A complicated UTI. So of course, males fall into complicated UTI. Structural issues with the patient would be a complicated UTI. Immunocompromised patients, patients that are at elevated risk. So patients that are elderly, patients that have comorbidities. If you want to rule out interstitial cystitis, so you want to know, is there bacteria there that's causing symptoms, or is there no bacteria there? And I could probably start moving down interstitial cystitis. Also, if you have patients that have known antibiotic allergies or any type of hypersensitivities, there'll be options. And it's a wonderful way to really be able to treat those patients that you know cannot take certain types of antibiotics. So we've talked a lot about the science behind guidance, but we also are very proud of our body of literature. So currently we have 19 peer-reviewed publications that we're looking at all different topics within guidance UTI, how it's used in patients. And I just put a couple here on the screen. The QR code on the right-hand side, you can scan it, and I'm sure we'll share this. You can scan this and you can look at all 19 publications. So it's really wonderful. And these are all peer-reviewed. The two on the left-hand side, I wanted to highlight. One of them is looking at improving patient outcomes and using guidance UTI. So we looked at patients treated with standard urine culture compared to guidance UTI treated patients. And we saw a 40% reduction in hospitalization, emergency room visits, urgent care center visits, and a 50% reduction in empiric therapy. And this is huge because we can sit and talk all about the science, but bottom line is you want to make your patients get better. You don't want them to end up going to the hospital and getting into these dangerous situations where sepsis can come in and having to retreat and really breaking this cycle of reoccurring UTI. So it's a wonderful tool to see that is that 40% significant reduction in hospitalizations and emergency room visits. And conversely, we're also seeing reductions in treatment costs, so that the minute you start reducing hospitalizations and medications, you're also reducing treatment costs. And this was in urology, urogynecology settings. And we've also seen this in Medicare patients, and we've also done the same in home health settings. And then the other one is the discordance. So we've talked about the presence of an antibiotic resistance gene and the discordance between antibiotic susceptibility. So just because you can detect an antibiotic resistance gene 40% of the time does not mean that it's being expressed. So that just looking at the genotype information differs in 40% of the time of the phenotype of what we actually see when we give a patient this antibiotic. I love this. This is our test, our patient report. And you can see that the top part is the organisms that we find. We give you a semi-quantitative value to these organisms. You could see the antibiotics across the top. We give you the formulation. That's number 2. Number 3 is our pooled antibiotic susceptibility test. And that's really the line that we all look at. We look at the green S or the red R's. So you could see the green S means that it was sensitive to this antibiotic. That patient sample with those organisms together showed sensitivity, or you see resistance. And those would be the ones you would not be choosing that had full resistance to these antibiotics. And you could see line 4 is the detection of the antibiotic resistance gene. It says it's there. And this is where I want to highlight is you can actually see the presence of an antibiotic resistance gene is there. But in many cases, you can see it's still sensitive. It means that antibiotic resistance gene is not being expressed. And that would be something that could open up a new antibiotic. Conversely, you can see on the right-hand side resistance, as you could see the presence of an antibiotic resistance gene in resistance, but you can also see that there are places where you have resistance, but there is no antibiotic resistance gene present. And that essentially means that there are these bacterial interactions where these organisms are shielding itself and protecting itself from antibiotic treatment. And it doesn't have to have an antibiotic resistance gene. It could use efflux pumps. It could use inactivation of an antibiotic. There's many other mechanisms. So our test is really important that it captures these bacterial interactions. And of course, at the bottom, you do see the check marks. And these check marks are just, it's not patient specific. It's really just looking at what's in the scientific literature, what's approved by the FDA, and to treat these individual organisms. So in conclusion, we know that the most important things to treating these reoccurring UTI patients effectively really is good clinical history. Know your patient, know the background of them, and really how their overall health is. Choosing an appropriate diagnostic platform that will really capture the organisms and the resistance, and looking at also at susceptibility, and then leading into choosing the appropriate antibiotic to treat your patients. So that's when our pooled antibiotic susceptibility comes in. Having that real-time look at what that antibiotic is going to do with a polymicrobial UTI before you give it to a patient, which is really the most valuable piece that we can offer them. And so in conclusion, I thought this is my fun agar plate laboratory picture, is really just having that accurate, comprehensive view of that detection that you look at for a UTI really is what's going to help you with your patient antimicrobial stewardship programs. So thank you. I hope this was helpful to everybody to kind of give this overview, and I appreciate your time, and thank you so much for inviting me to be on this program.
Oh, absolutely. That was a great presentation. I love the slide that shows the culture result. I mean, compared to what we're used to seeing, there's just so much more information to be garnished from that.
Thank you. Thank you. It's really interesting to see how diagnostics has changed, how we've changed how we look and look at UTIs, where we were in the 50s and just saying urine was sterile, and that if you can detect an organism, that there was a UTI, and we could detect E. coli because standard urine culture grows beautiful E. coli, a lot of gram positive. It does not like to grow gram negative, and it will not detect any of the fastidious organisms that we know that are there in the bladder. So it's really fascinating. And now Pathnostics is also looking now at biomarkers. And so we're starting to publish, and that's also on that QR code, looking at biomarkers to help with these UTI patients. And there's a lot to be said about that. So, we can talk a little bit more, but I'd also love to answer any questions. So
yeah, with that, if you have any questions, please put those in the comment box. Since I have a large number of panelists, if you give me a little heads up that you want to ask a question, I'll go ahead and bring in. Lori, go ahead.
So for this test, would it be recommended or would it be better to send off a straight cath urine sample as opposed to a voided?
Well, that's really interesting because and this is actually one of our most recent publications that was with that QR code, is a lot of people have said that they would like to use catheterized urine because they're worried about contamination. And what we have seen is that in one of our publications, we've compared midstream voided urine versus catheterized urine specimens and looked at uropathogens on this guidance test and see what are the frequency, what are we finding? And we're finding them almost in very similar frequencies in the bladder in that catheterized sample versus midstream voided. So it's fascinating to think because, again, we think a lot of these organisms in the past we would think maybe would be contaminants, but we're seeing them in the bladder. So we're seeing them in catheterized and midstream voided samples. So you could do both. We're seeing them easily in midstream voided as well as catheterized at very, very similar frequency. So we take both. So we feel that whichever way you would like to send us those samples would be just fine. But take a look at that publication that compares these uropathogens, the frequency that we see them. And we looked at the classical ones, like what we talked about, E. coli, Klebsiella, and Proteus. Those are the emerging ones are more like Gardnerella, Actinidium shallii, Mycoplasma, Uroplasma. Those are the ones that are more the emerging ones. And we're seeing them at very similar frequencies. So it can be either way, either specimen types.
Great.
We've been using this test for probably about a year now and have some great results as far as these recurrent UTIs, persistent UTIs, things like that, where, they've been suffering for so long. And then we get this test and we treat them with the correct antibiotic, and it's amazing.
Thank you. Thank you. It really is a wonderful test. It's a unique test. So,
Andrea, go ahead.
Yeah, thank you, Dr. Lee, for that presentation. That was really great. Few things that I love, and Vic mentioned one of them already, is putting all the sensitive ones on one side and the resistant ones on the other, because we all know those urine cultures, a tiny little font, and you're trying to make sure that you're not mistaking one for the other. I also love that you include fosfomycin sensitivities on this test, the fast turnaround time as well. I've got a lot of patients sitting right now over the weekend and they're waiting for their urine cultures because it's 2 to 3 days. So removing that time barrier, I think, is going to be great. But I do have a question about, do we have to send this out? What's the cost and what's the logistics of ordering this for my patients?
Well, it is a send out test. And so we collect 2 tubes of urine. So it comes in a little kit that you can keep in your office. And so it's a small amount of urine in two tubes. And what you do is you will collect from the patient, put it in these 2 tubes, and send it to us overnight. And so it will hit our laboratory the next day. So we do a FedEx. And so we collect it the day that you collect. And then the next morning we run it. And we will run the PCR and that pooled antibiotic susceptibility at the exact same time. And it's really wonderful because it gives that really short turnaround time. And our turnaround time is less than 24 hours upon receipt to the laboratory. So that if it hits the laboratory in the morning by FedEx, within 24 hours. And we're seeing some that, are even less than 24 hours. And that's fantastic. So when you have a symptomatic patient, you don't have to wait as you do with a urine culture and wait days to kind of get that result. And Thank you for that comment about our patient report. It's really nice to have the green S's and the red R's. So as a clinician, you're very busy. You have all these patients running around, and sometimes you don't have more than just a short handful of minutes to sit and to look at that patient report. And it's really wonderful to see in a eye-catching way that you can see the green S's, and you already know the formulations because we put that there as well. And it's just a really nice comprehensive view at pulling all these things that we talked about together today into just that one nice little page, one line for you to treat your patients. So,
and are the results faxed to the office, or is there a portal?
Both ways. And then when it comes to coverage, we have 0 out of pocket for our Medicare patients, 0 out of pocket for our Medicaid patients, and then we are part of all sorts of commercial payers. So, and we also have a program called Pathnostics Promise, so that patients that really have a hard time affording their bill, let's say if it's a commercial payer and they have a high deductible, they can call us, and it comes with every kit, and we can lower it down to an in-network price, and it's about $50. So it's wonderful that for the patients that need to test, that they can test, and the price is not an issue with affording that test.
Yeah.
So
the only thing worse than a urinary tract infection is a big bill.
I know, I understand. And that's something that's kind of scary when you're talking about molecular diagnostics. And a lot of clinicians are like, oh my goodness, I don't want, my patient to receive a big bill.
Yeah.
And that's why we have we work very hard at making sure that we have these programs that help these patients be able to test and not have to worry about this. And Pathnostics promises, one, that it's in every kit, and we have all our team is always happy to come in and to help the staff with just making sure that they can come and test and not have that worry. So
that's really great. Lacey had a question.
I did. A couple questions actually, and follow up a little bit with Lori's and Andrea's questions too. So I know a big frustration for patients with regular urine cultures. Well, one, not only do they have to wait a few days, but two, there's nothing worse than when you get that report 2-3 days later and it just says mixed flora, right? So wanted to make sure that that's something that doesn't happen with your test. And secondly, when we're talking about logistics, tubes, and how you collect it, how you send it, etc., is this something that always has to be collected in office? Is there a kit that perhaps could be drop shipped to patients that might be far, something prior to surgery? I don't know. How do you have any of those options?
Yes. So, so sitting and talking about the mixed flora contaminated, you will never get a contaminated result from us. And that's really nice, because that's what culture does. Is culture can grow one organism really well, but when you start doing 2 or 3, you get a whole agar plate of kind of a mess of organisms, and we can't figure out what's going on. And that's when you get that contaminated result. And that's what makes PCR and that guidance UTI test so different, is because we will look for those clinically relevant organisms using PCR. So there isn't a limitation, and you're not going to get a contaminated result. And that's fantastic. So you'll always know what you're dealing with. And that's wonderful. And then when it comes to the collection, you can collect in your office. We have little kits that you can collect just urine sample from a patient, midstream voided, and that's really great. You can also do catheterized if you prefer doing it that way. But we also have home kits, and that's really wonderful, because sometimes you may not have a patient that physically can come in, or you can't see a patient in office until a week from now, and so you can call our office, or we have a requisition form. You can fill out a requisition form and put the information for the patient, and Pathnostics will directly send that kit home to that patient. And then we follow up. We'll follow up with the telephone call, and we'll talk them through doing that collection. Again, it's just a urine sample at home, and then we'll arrange for a FedEx pickup for that sample. And so it's a really nice service, so that patients that you can't see, patients that can't come in, we can have it directly sent to them. They can collect at home. We'll arrange for the pickup. It'll be sent to us, and then you're going to get that result. And so it's just a nice service to offer. So we both have answers both in-house. You could do it in-house as well as our home kit service. So.
Good to know. John, you're quiet today.
Oh no, I have some thoughts.
Go ahead.
Okay, I know we're talking about diagnosing the UTI, but make sure that you, obviously we all do, prevention is key. And for a lot of women are more commonly the victims of these recurrent UTIs. Make sure you address the topical estrogen, the vaginal atrophy, the genital urinary symptoms of menopause. Make sure that is addressed to prevent UTIs. A lot of my female patients don't understand that when I prescribe this topical estrogen, it's not just for the vulva, it's also for the bladder. Mm-hmm. Also, from the coding aspect, I have to throw this in. If you are looking at the patient and billing based on medical decision-making, urinary tract infection is actually a level 4 visit. If you know about the risk, data, and problem. It's not really the problem, but the data is actually 3 points, which gives you a level 4 data. And then if you start the patient on an antibiotic, that's prescription drug management, that's also a level 4 risk. So a 4 and a 4 gives you a 99214 or a 99204.
Yep, and you're absolutely right. And we didn't talk today about prevention, but you're absolutely right. So when you're talking about preventing and talking about estrogen and working with these patients, it's a very important topic to talk with them, and it's impactful, especially also when you're talking about the bladder. So yes, very valuable, and I'm happy that you spoke and chimed in on that. It's very important that we talk about that for our patients. So as well.
And Lori, you had a question?
Well, I had a comment, which was nice. Once you draw up those urines, it's nice that it doesn't have to be refrigerated, and they can literally sit for 5 days.
Yep.
So if you're stuck on a weekend, it doesn't even have to be sent out until that following Monday. Of course, you don't want to delay it, but if that's the case, it's late on a Friday. And they arranged for us, because we're in an office where they do pickups, they arranged for a FedEx box to be on our door, so we could just leave it outside the door and it's picked up on a daily basis.
So we prefer the urine to be at room temperature, because remember, we're looking at bacterial interactions. So we want them to be interacting, and we want them, so we prefer that sample to be at a room temperature. And we have until about 5 days. So as early as you can. So if the urine's sitting there, please send it to us, but you have a little bit of time, and that's really nice. So at about 5 days is our cutoff. And so it's really wonderful. It gives you just a little bit of leeway, but FedEx has been working really great for us, and we arrange that pickup. I know Lori, offices have pickups as well, that you can have that sample picked up by FedEx. It hits the laboratory the next day, and then that's when we start going and working on our guidance UTI test and getting those results to you. So,
well, great. It's been a really great discussion. I think we learned a lot of information, and again, a great test. I had mentioned earlier when we first were talking how much I was trying to get somebody from this type of organization to talk for our group, because I think it's really important information to know. I always joke about it's easier to tell a patient they have cancer than a negative culture, because patients just freak out when what do you mean it's negative? It's
I know.
And so now we're finding out that maybe we weren't right. The test wasn't good enough. So it's good to have other options. As I always say, it's a full toolbox really helps out. So it's great to have this stuff here. I'm going to make a plug for next week's show. Next week, we are going to be doing it live from the Chicago Metro SUNA conference. So the time change is a little bit different. It's going to be 9:30 that will actually be going on. And we have Suzanne Qualich, who's spoken on our show before. It's going to be addressing pain in the scrotum, when to be concerned. I may get on a little before 9:30 if I can open up the cameras sooner. But for sure, join us at 9:30 for that. And then just as I mentioned, for those of you that are not in the healthcare profession, you're an actual patient. You can always check out our Uropatient podcast, which follows this show at 10:30 at uropatient.com, all the information you want for that. And again, I'd like to thank all of our great speakers and great experts that joined us for today. It was neat to have everybody on. It was kind of a fun experience to have a full screen like this. So we'll see everybody next week, and enjoy the rest of your week.
Thank you for having us.
Bye.
Thanks.
Bye. Thank you.